In today's class, we will be discussing about derived parameters from pulmonary artery catheter. So first is the transpulmonary gradient. It is the difference of mean pulmonary artery pressure minus pulmonary capillary wedge pressure. It is actually the pressure across the LV and RV, that is in turn it indicates the pressure across the lungs. So more than 12 to 15, usually less than 12 millimeters of mercury, more than 12 to 15 millimeters is abnormal, and more than 15 millimeters of mercury is seen in pressure overloaded right heart failure. So that is transpulmonary gradient. Next is pulmonary vascular resistance. So it is transpulmonary gradient divided by cardiac output. That is mean pulmonary artery pressure minus pulmonary capillary wedge pressure divided by cardiac output. More than 2 Woods unit is abnormal and more than 5 Woods unit is seen in pressure overloaded right heart failure. While systemic vascular resistance is mean arterial pressure minus CVP divided by cardiac output. Normal value is 800 to 1200 dynes per second per centimeter raised to minus 5. It is the summation of the arterial, arteriolar, microvascular and the venous resistance. So it is a pressure difference divided by, both are divided by cardiac output. One is the MAP minus CVP is SVR, and mean arterial pressure, mean pulmonary artery pressure minus pulmonary capillary wedge pressure divided by cardiac output is pulmonary vascular resistance. Diastolic pressure gradient is pulmonary diastolic pressure minus pulmonary capillary wedge pressure. Normally it is less than 5 millimeters of mercury. If it is more than 5, it is abnormal. More than 5 to 7 indicates pulmonary vascular disease, and more than 7 mm is seen in pressure overloaded right heart failure. Pulmonary capacitance, that is the capacity of the pulmonary capillaries to hold the blood. So it is stroke volume divided by pulmonary artery pulse pressure, that is pulmonary artery systolic minus pulmonary artery diastolic pressure. So lower values is poor outcome, that is capacitance should be more, that is it should be able to hold more blood. Less than 0.81 ml per millimeters of mercury is seen in pulmonary artery hypertension, and less than 2 ml per millimeters of mercury is seen in right heart failure. Next is left by right filling pressures, left pulmonary artery wedge pressure divided by CVP. Higher values indicate poorer outcomes. Next is right ventricular and left ventricular stroke work. So stroke work is how much pressure against which the RV has to pump. So mean pulmonary artery pressure minus CVP into stroke volume into 0.0136. That is the pressure across the pressure generated by the RV. That is mean pulmonary artery pressure minus CVP. While in LV, the LV stroke work is that is the mean arterial pressure minus pulmonary capillary wedge pressure into stroke work into 0.0136. So there is limited data for left ventricular stroke work in cardiogenic shock, while in right ventricular stroke work lower values indicate poorer outcomes. Next is pulmonary artery pulsatility index. Pulmonary artery pulsatility index is PA pulse pressure by mean pulmonary artery pressure, while aortic pulsatility index is aortic, that is the pulse pressure normally, that is systolic minus diastolic by pulmonary artery wedge pressure. So one is PA systolic minus PA diastolic, that is the PA pulse pressure divided by mean pulmonary artery pressure. Here it is in LV, it is systolic minus diastolic by pulmonary capillary wedge pressure. So pulmonary artery pulsatility index values will be lower in right heart failure. If there is a pulmonary artery pulsatility index more than 0.6 in post VA ECMO associated patients, it indicates better hemodynamic response. Similarly, aortic pulsatility index lower values indicate poorer outcomes. Next is cardiac power output index. Cardiac power output index is cardiac index into MAP minus CVP. That is how much power the heart is generating. So it is the CVP is a right-sided filling pressure and it is generating a MAP. So MAP minus CVP into cardiac index divided by 451. Lower cardiac power output index, worse outcomes, and better will be if the CVP is more than 8. And we have to aim for a cardiac power output index of 0.28 to 0.3 watts per meter square for a patient in cardiogenic shock or impella. Diastolic shock index is heart rate divided by diastolic BP. It is a degree how much the patient is vasodilated. If the value usually is more than 2 is seen in septic shock, and higher values indicate poorer outcomes in septic shock patients. Thank you.